for us as healthcare providers, sometimes I've basically modified a talk that I give to explain ILD to medical students and people like that, and I've modified it to be more of a be more patient friendly. So this is kind of the most important slide, I think, for especially when I'm teaching younger or other doctors about ILD and medical students, which is that what we're trying to do in our initial evaluation is to understand, is somebody's interstitial, what is like the underlying cause of someone's interstitial lung disease, because that's going to help us understand how to treat them. To me, I really break up the what I'm trying to the host of many different ILDs into three big categories to sort of simplify it and understand the approach. One is your ILD caused by something you've been exposed to either in your work or in your environment at home, or throughout your life, or through medications you may be treated with for other conditions? So those include things like asbestos. There are some ILDs that are really specific to cigarette smoke exposure, medications like amiodarone, and then of course hypersensitivity pneumonitis, which is a lung-specific sensitivity to things like birds, mold. Also, you can have fibrosis in the lungs after experiencing radiation therapy, which some of you may have had for cancers and things like that. So that's kind of one big block. The second big block and cause of ILD is systemic or autoimmune diseases like rheumatoid arthritis, scleroderma, Sjogren's, antisynthetase, sarcoidosis. These are diseases that can affect a patient's entire body, but also can cause lung scarring. And so in those cases, the lung disease is part and parcel of a bigger sort of systemic disease that can and may be affecting other parts of the patient's body. And then the third big category is the idiopathic kind, where IPF and now falls. And we now understand that to some degree, even though it's idiopathic, we're understanding that there are genetic factors that may be playing a role there, and that's something that's an area of a lot of research, and we probably won't talk about too much in this particular talk, but maybe at a different time. So what this slide is really trying to give you guys a sense of is that the diagnosis and a physician putting you in one of these three categories is really a synthesis of our history, talking to you, physical exam, radiology findings, labs, and pathology, because different kinds of lung diseases in these bins have distinct lab findings, often have distinct radiologic features, so different patterns on the CT scan, and when biopsied, that can really help. If we have tissue to look at, it can help us put you in one of these three bins.
Doctor, before you go to the next slide, can
Yes.
I ask a question?
Sure.
Going back to the previous slide, how do you detect say, a cause of mold or some other pathogen? Specifically in testing, they do an antibody panel
Right.
or hypersensitivity panel, but do you look for mycotoxins and things like that?
So unfortunately, there's no no test with really good performance characteristics. And this is one of the biggest challenges for us. I think if there was a blood test, we would all say like, hallelujah, this is like the greatest day ever. Because there are antibody panels to look at for like sensitivity to mold and certain bird antigens and things like that. But the reality is the sensitivity and specificity, so like how well that test actually performs in real life for patients is very variable. And it is the case that in different case series, I've looked at tons of patients with like true hypersensitivity pneumonitis, meaning they've been biopsied or is a very clear diagnosis. Even in those cases, up to 50% of patients, we don't even understand what the antigen is. We don't know exactly what it is in their environment that's causing that hypersensitivity. So it's very common to have pretty confident diagnoses of hypersensitivity pneumonitis, often biopsy proven, where we cannot say for sure what the antigen is. I think for many of us, especially us that live in homes that may be older, there are molds in our environment all over the place. And often in some homes and such, like I have one patient who had an apartment that he stayed in a lot that had had a flood. And when we diagnosed the hypersensitivity pneumonitis, he started staying somewhere completely different, and a lot of his symptoms got better. Now, his ILD, there's some amount of the lung stuff that was irreversibly damaged, but he certainly started to feel better and had improved function after getting away from that. But it's really hard. There is no definitive blood testing. It is really a synthesis of the story, like really thinking with the patient, where are the places you've been, what are exposures that you've had, et cetera, and then looking at specific findings on the biopsy or bronchoscopy results that can tip us towards that direction.